Hello and welcome everyone. Thank you for joining today's discussion. I'm Hemi Tewarson. I'm the Executive Director of the National Academy for State Health Policy, otherwise known as NASHP, and we're so pleased you're here today with us. We're going to have a fantastic 45 minutes of discussion where I hope you learn something new and ask questions. Just to give you some background, last fall, I'm hosting this discussion along with the Robert Wood Johnson Foundation. Last fall, RWJF and NASHP awarded Medicaid Innovation Awards to Medicaid departments in 6 states. And we were so pleased to provide these nonpartisan awards to recognize states for demonstrating creativity, leadership, and progress in their Medicaid programs. This kind of recognition is really important. As I'm sure many of you know, Medicaid has faced significant challenges in recent years. And so taking a moment to celebrate the bright spots and learn from one another is empowering, and we are happy to lead however we can. Just to remind everyone, if you haven't been following who was provided those awards, we had 6 recognized states. 2 of those states are represented in our conversation today, and the previous states were recognized in previous webinars. Kentucky was recognized for streamlining enrollment. North Carolina for improving access to care, and we'll hear more about that today. West Virginia for improving care coordination. Minnesota for addressing health disparities, and again, that will be a topic for today's discussion. Arizona for addressing social determinants of health. And California was recognized in the category of promising emerging initiatives. Today, I'm so pleased to be joined by Dr. Nathan Chomilo. He's the Medical Director for Medicaid and MinnesotaCare in the Minnesota Department of Human Services, and Dr. Shannon Dowler. She is the Chief Medical Officer for North Carolina Medicaid, North Carolina Department of Health and Human Services. So we are going to hear more about both of the innovations in these 2 states over the next 45 minutes. But of course, 45 minutes is not very long, so we're really going to be able to just hit the highlights. I really encourage you all to ask your questions in the chat. We are going to reserve time at the end of the webinar to make sure we can get to as many questions as possible so that you can get some of those answered during this discussion. I also wanted to just say, I hope you feel like you walk away from this learning and something for your own state. And so, there'll always be opportunities to follow up afterwards as well. So today we're going to start with Minnesota to hear more about their program. They were awarded the award for their efforts to address longstanding health disparities through their Medicaid program. They engage community members to inform recommendations on how to address racial equity for Black Minnesotans. The recommendations address enrollment and renewal, increasing access to culturally relevant care, and engaging communities and families served by the program. So I'm so pleased to turn this over now to Dr. Chomilo to tell us a little bit more about how they approach this work. Turn it over.
Yeah, thanks, Amy, and thank you, and thank you everyone for joining. Happy to be here representing really a team effort, and as I said when we accepted the award, that team includes the community and the communities that we serve in Minnesota Medicaid, who we couldn't do this work without. And so, but I'll take us back a little bit because Minnesota's long had a good history of identifying disparities. Minnesota Community Measurement has put out a disparities report going all the way back to 2007 that's looked at disparities in quality measures based off of how people get their health care insurance. But really, there's been a desire to move beyond measurement. And so I joined the agency in January of 2020. And several years before then, my predecessor, Jeff Schiff and Fritz Onsong, they started a program called Integrated Care for High-Risk Pregnancies. And this was really a community-led, community co-created perinatal care collaborative that really took the kind of design of the model, defining what was going to be quality outcomes and who would be granted and awarded the grants out of DHS's hand or Minnesota Medicaid's hand and put it more firmly in the communities most impacted by these disparities. And so that work was already underway. And when I joined in January 2020, I wanted to continue to look at structural inequity and how structural racism was showing up in our Medicaid program, and really then engage in a community-guided process to help prioritize our work going forward. Because there's so many different ways that we could actually get to health equity, that we could address these disparities. And I really wanted our approach to continue to be more community-centered. And so that's what the Building Racial Equity in the Walls of Minnesota Medicaid report was. It was starting by identifying communities most impacted by structural racism. And so when we looked at our data, we looked at our quality metrics. We saw that not only were Black Minnesotans usually had some of the worst outcomes, but if we look even more specifically at US-born Black Minnesotans, that we know that they actually had some of the worst outcomes amongst our programs. And then we looked across our state at how Minnesotans usually get access to healthcare. Black Minnesota communities, 44% of those who are 64 under the age of 64, get their health care through Minnesota Medicaid. 64% of our Black Minnesotan children get their care from Minnesota Medicaid. And so it was really important to, focus on where we could play a role in addressing the health and racial disparities specifically. And so we met with Black Minnesotan leaders to talk about what are the levers, within Minnesota Medicaid that could really help start to better address and focus on the disparities that we see, thinking about eligibility and enrollment, access, quality measure,ment, and then what I framed early opportunities, again, recognizing that both not only children, but our birthing persons and mothers are disproportionately covered by Minnesota Medicaid. And we took that initial guidance and back and met with met with policy staff. And we really wanted to come up with some short, medium, and long-term approaches that we could do to really tackle these health disparities and structural racism within our program. And so using those first two steps, we kind of drafted our calls to action. We brought these back to the community again to help prioritize what those calls to actions could look like. And then we incorporated all of that into the report, along with pairing it with evidence that really showed that these ideas and these priorities that were community derived, they are specific to our community, but they're also not novel. And there are a lot of same challenges that have been documented in the health services research before. And so really just trying to elevate the importance of this being a priority that we took as a state going forward.
Thank you for sharing all of that. You talked in the beginning of your comments about the importance of community and really being community at the forefront of all of this. I think there's a number of state leaders that we've been talking to that really want to think about how to better engage community in efforts to address disparities and advance health equity. What were some of the challenges you encountered? And do you have lessons learned to share with folks who may be listening today?
Yeah, I think personally, like resources, I was hired in 2020, actually in a part-time role with the intent of having a dyad, but then the pandemic hit. We had a state hiring freeze for about 18 months. And so I really didn't have a team. And, there was not only the stresses for us within Minnesota Medicaid, but the community in trying to do a community guided process, you'd have to really be cognizant of the stresses they are facing. And, again, I opened up again, thanking the community because there's a lot of historical trauma and mistrust between the state and US-born Black community and other communities that have suffered historical oppression. And so really, you really need to kind of create relationships. I, come from Black community in Minnesota, so I was able to lean on relationships I had. But, seeing as we go and engage with other communities where those relationships might not naturally exist with staff members in our agency, how do you create that, the relationship in an intentional way so that there can be those trusted messengers that help, foster this type of collaboration moving forward. And so, yeah, I think, resources as far as just having the people and then having the time and patience to do the work to either repair relationships with communities where, trust has been broken or foster trust where it really never existed.
Yeah. And appreciate your leadership on this. This is not easy work. What would be curious, how are you thinking about sort of the future of this initiative? Where is it going? And we're coming up until the end of the public health emergency, specifically with the Medicaid continuous enrollment requirement ending, but then of course, everything else that might come with the end of the public health emergency. What's next for the work in Minnesota?
Yeah, so we're already underway on the next report to again help guide our calls to action, the work of our agency, the recommendations that we put forth for our governor. And the next report will be focused on American Indians in Minnesota. and looking to take the lessons we learned about what worked, what didn't, along community engagement, and thinking about how can we do a better job of doing things like actually reimbursing folks for their time. This, because of those personal relationships, we're able to just ask people to trust us, and that we would honor their time by actually helping these recommendations come to life. But really, how do we try to find ways to value the time and the co-creation that goes into it? And then one of the hopes for the report was not only to just have some concrete calls to action that we very much are going to work on and are working on, but also to kind of model for other state agencies, other Medicaid programs, other healthcare systems, those who say that they're really committed to addressing structural racism in healthcare and healthcare disparities, that this is a process that you can do. It takes time, it takes intention, reflection, but like the hope is to see other parts of healthcare think about how they can have a more community-guided, community co-created process. And I think that's even going to be more important, as the public health emergency ends, and as we lose maybe some of those federal resources. How are we really thinking about making sure we continue to maintain that priority on those communities most impacted by structural racism and structural inequity going forward?
Yeah, thank you for sharing that. And then probably my last question, then we'll hear more about from North Carolina. And then please, those of you listening in, put your questions in the chat. We will have time in the end to get to some of those. So my last question for you for now is thinking about those who are maybe just starting on this journey or in a different place and really thinking about how do you address health disparities. Do you have any, advice for them? It sounded like the report was a really important first step for you all to identify priorities, but curious, what advice you might have for folks listening in.
Yeah, so invest in the work, so talked a little bit about the importance of paying community co-creators for the time. That really, requires us to invest in a robust community engagement team, that has the budget to pay community co-creators, and it really is, non-traditional, but they have some of the best ideas, and it's really hard to kind of capture that in even the position descriptions we put into our role. And so really having a robust community engagement team with a budget, invest in the infrastructure to look at your data, through a number of different demographic lenses, but really do it with the idea that you're not going to stop there. You're not going to just measure it and put out a report, but use that data as a signal to where you then need to engage more or deeper. And then the last one is really important, is be prepared to lean into discomfort. A community co-guided process can feel more messy than how we usually conduct business at the state. It will be uncomfortable to hand over power or direct stewardship of resources, but that's really what is necessary. And there'll be lots of questions and pushback from other parts of your agencies, other parts of state government. And I really, would ask folks when confronted, ask whose comfort and needs are being centered. And if it isn't the enrollees or communities you're aiming to serve, then you really should continue to find ways to push through. And so really be prepared to lean into the discomfort if you're really intent on addressing structural racism, structural inequity that lead to these disparities.
Thank you for sharing that. So we're going to have more time to talk with Dr. Chomilo as we get towards the end of our programming. But for now, we're going to switch now to hear more about North Carolina. So Dr. Dowler, North Carolina developed a maternal perinatal telehealth policy during COVID-19 that provided telehealth and home visit care to patients, provided reimbursement to perinatal providers from remote blood pressure monitoring, physiological monitoring, and lactation services, and conducted postpartum depression screenings by video, phone, and online portal messaging. So would love to hear more from you about the program and where it's going now. So I'll turn to you now.
Great, thanks. And thanks for having me on today. North Carolina was a little unique in that our offering for North Carolina Medicaid and telehealth were essentially non-existent prior to the stay-at-home order from the governor. So we had a lot of work to do. We'd actually launched a telehealth modernization work group in December prior to the pandemic, just a few months before. And at that time, we projected this 3-year time frame for us to establish the framework and the money and the authority to do the things we wanted to do in telehealth. Instead, we did it in 6 weeks, like many of our friends around the country. We sort of took the approach of do it now, ask questions later. we set up an evaluation on day one before the first policy turned on so that we could understand what was happening as we were doing it. But we were pretty liberal in throwing things at the wall to see what would stick because we just didn't know what was coming. We developed this calendar of telehealth modernizations, and we had weekly provider webinars. And each week we would review what we turned on the week before, what was new that week, and what was coming in the week ahead. And we'd have thousands of providers and practice managers each week on our webinars, leaning in, trying to understand what was coming. And the feedback from those sessions really helped us figure out what we had missed. So what had we failed to calendar? Who had we not thought about? And so every time we thought we were done, at first we thought it was going to be 3 weeks of modernizations, and it ended up ultimately being 6 weeks of modernizations because providers kept raising their hand and saying, hey, what about us? We need to be able to access members as well. And so we would then say, hey, thanks for raising your hand. We're now going to meet with you to understand what it is that your specialty or your type of service needs for us to cover. We also had a statewide telehealth work group we set up with a variety of stakeholders in the medical field and outside the medical field, really leaning on an equity lens to help us understand not only what should we set up, but how should we start thinking about winding down? Because at that point, we thought the pandemic was going to be like a few months. We had no idea we'd be looking at years and years of coverage for things. So that was sort of the background of how we got to where we are today.
Yeah, no, thank you for sharing that. And so curious, I think we're at such an interesting time. I feel like the telehealth policy has like accelerated. We've done like 10 years of work in the span of like 2 years, right? Sort of across the country. And we're at a really interesting time about like what's next for telehealth. How do we sort of think about this on a permanent basis? I'm curious, Dr. Dowler, kind of the experiences you had sort of in this context for North Carolina. How are you all thinking about that moving forward? And what will come next from your lessons learned here?
Yeah, we continue to learn as we go. Right when we think we've got a grasp on things, we realize that we've got a whole nother bucket of work that we weren't thinking about. So I think one of the things I would love to see happen is, because providers were so overwhelmed and there was so much going on for them at the time, they didn't pick up some of our coolest initiatives. And I don't want those things to go away. We had this opportunity to really innovate, and I don't want us to lose the chance to innovate. So we've turned a lot of things into permanent policy. Back in June, we actually finalized what was going into permanent policy for the state across all the different categories. And we created a public facing way for people to tell us, hey, you missed the boat, or wait, you forgot about us. And, for us to consider what the evidence base is and whether we want to continue those things. We continue to work on a few areas. So I mentioned innovation. One of the coolest things we did, which we stood up, was this hybrid home health telehealth visit. And so essentially, you take a physician home visit, which pays at a much higher rate than an in-office visit, because of course it costs money to send a physician out into a patient's home. But that's not great for access, because you actually reduce their productivity and you decrease access for other patients during that time. So we created this hybrid visit where, for the same amount of money, that same physician home visit, we'll pay you to send a staff member, a trusted staff member, to the home, where they might be able to do, Dopplers on a pregnant woman, or check a urine dipstick, or do a set of vital signs, or give vaccines, or draw lab work. And they coordinate that telehealth visit with the provider in the office, who can say, hey, I'd like you to measure fundal height and show us what that looks like, or I want to look at this diabetic foot. So that you have this population that might have mobility challenges, or pregnant women on bed rest, or maybe someone with severe IDD where the office visit is just so disruptive to them and their families, that we could maybe come up with this hybrid way to provide care as well. And so we were super excited about that modality, but the field just didn't really pick it up that much. And I think it's because there was just too much going on for them to think about, how do I stand something up like this, even though it pays well, and we made it so the ROI is good for practices. They've just got too much going on. I think that's true on the broader telehealth framework as well. Every payer is covering something different in a different way with a different set of rules. And so practices are just completely overwhelmed. And so we're working now, we have a payers council in North Carolina where we're working to create a new updated version of telehealth offerings across all the payers, so that providers can have on one sheet of paper, at least the links to coverage, but hopefully sort of a simple version of what each payer is covering and whether it's temporary or permanent to try to help the field, because I think they're really struggling. And the other next thing is I think folks are really wondering, like, what's the big picture for us? And so we are going to put out a telehealth white paper where we're going to review all of our analyses that we've done over the past 3 years, which are many, to help them understand what we saw. For instance, we saw that equity wasn't great. So even though there's this promise of reducing health inequities by race, ethnicity, geography, in fact, we saw white urban members getting telehealth services. And so how are we going to address that, and what are we going to do about it? So we are going to put out a white paper. We're also doing an analysis of the hospital at home model, which was something that CMS temporarily allowed, to understand how that worked and what was the equity impact of that. So we have a lot of work ongoing with evaluation of the programs.
Yeah, no, that's really helpful to share. And such an interesting point on the disparities piece of what your evidence showed you. Curious, so, states are thinking about different telehealth policies, just like North Carolina, and reflecting on, what was the impact of what we did during the pandemic? Should we make it permanent? How should we be thinking about moving forward? Where are there gaps or challenges? If you had any, what would be your sort of advice as we all collectively think about sort of the future of telehealth, from this specific experience you've had in North Carolina and sort of looking forward?
I think the biggest thing that was a surprise to me is there's this promise of telehealth. Every provider type that wants to do telehealth is saying this is a great equity issue. We're going to improve access. And as I said before, that is not what we saw actually happen in the field. And so even though we're seeing steady improvements, we've been measuring it quarterly. So the likelihood to use telehealth services if you're Black or Latino or you live in a rural area is slowly improving and approaching that of the white member, the white non-Latino urban member. We're still not there yet. We had our CAP survey. We added on some telehealth questions specifically, and we learned something really interesting. And that's that white beneficiaries were much more likely to be offered telehealth than non-white members. But they were equally willing to accept telehealth. So our white and non-white members were just as likely to lean in and accept a telehealth visit. They just weren't being offered telehealth in an equal way. And so that's something that we're going to look at. So if you're not looking at that in your state, I would encourage you to. One of the other things we made this assumption that telehealth would break the piggy bank and that it would be all duplicative services and we'd never be able to afford it. That is not what our data is demonstrating. It's not doubling our costs. It's not duplicative. We were concerned telehealth might be low value care and actually create worse outcomes. Again, our data, though it's confounded by COVID, which makes it a little hard to tease out, so far it doesn't seem to be bearing this out from ER utilization or hospitalizations, tied to those modalities. I think the final frontier that we're working on and digging into, and I would love actually advice from other states if they're already doing this, is how do we dig into fraud, waste, and abuse? There are always going to be bad actors out there. And so how do we know who's a good actor and who's a bad actor? And how do we make sure our policies support folks doing the right thing who have really good intentions without overburdening them, but at the same time, make sure we eliminate fraud, waste, and abuse from the system?
Yeah, no, great points and a lot to think about as we move forward. One last question, then we're going to open it up to the audience questions. So keep putting them in the chat. We're going to get to as many as we can. So one last question for you, Dr. Dowler. You mentioned this, sort of not being offered in equal ways across populations. And so did you all do specific work with providers to try to educate them? And is that where the gap is? Kind of, what do you think is sort of an opportunity to improve upon that?
It's a little hard in North Carolina because we had so few telehealth offerings beforehand to understand, how much of it was providers just not having the bandwidth and the capacity to do it. I think when you have members who speak a language other than English, it's much more difficult to do telehealth.
Yeah.
And so how do we bring our interpreter services into a telehealth platform that creates a really good experience for people? Even to the point of the instructions for how to log on are in English. This assumption that everyone speaks English is challenging. I think the rural issue is we've got our big divide where people don't necessarily have access to broadband, or they do have broadband, but they can't afford it, or they don't have devices and minutes. So there's this piece too around how can we use our value added benefits and a managed care model to help make sure that all our members have equal access to the actual services themselves. There's so many different things we can continue to do to drive this. We did a public facing video it was sort of crowdsourced from providers around the state to say, hey, trust telehealth. This is a good model of care, because we saw that there was a lot of hesitancy and distrust about whether this was a good way to get care. And so I think there's work on all fronts to keep this moving forward in a way that's most positive.
Thank you for sharing all of that. So we're going to now pivot to the audience questions, and we probably won't get to all of them, but keep putting them in the chat. We'll get to as many as we can for the next 20 minutes or so that we have together. So my first question is for Nathan. So how have providers responded to your efforts to address equity?
I have heard mostly support. When I came to the role, I was very clear that this is one of the areas that I wanted to focus on, was addressing structural racism in healthcare, early opportunities for maternal health and early childhood in particular. So I don't think it was much of a surprise. And so from the channels that I'm connected to and the providers and organizations I work with, there's been a lot of support, and thanks for bringing the lens that I do from both the provider perspective and the health and racial equity perspective. I think we're still kind of early in the kind of process of thinking through how do we start really better structuring payment around some of these goals as well. And so I think that's where the rubber will certainly meet the road, as far as, being able to talk and have conversations. But then when we actually shift to how payment is structured, I'll be interested to see what the responses are at that point. But so far, I think folks really do appreciate the more community-led focus to how we prioritize our work.
I hope that positivity extends once you start having payment involved. So always a different conversation. The next question is for Shannon. So it's a long one, so I'm going to read it slowly. So how has telehealth accelerated enough, especially in rural areas where we can measure increased patient access? We have a serious doctor-nurse shortage in rural areas. Has telehealth helped us to see how we can actually provide for the 600,000 folks currently existing in the healthcare coverage gap?
That is a great question. And as many people know, North Carolina is not an expansion state, although we hope to be any minute. And we have a lot of people that don't have coverage in North Carolina. One of the things we did early in the pandemic was we created a hot spotting map where we looked at our members that had chronic disease and lived in rural areas. And we looked at whether the practices in those areas were offering telehealth or not. And if we had a high burden of chronic disease and no telehealth, we created a match there. And then we partnered with our AHEC, our area health education centers, to go out into those practices to provide resources and support. At the same time, our Office of Rural Health leaned into those practices and also helped stand them up. And so there's so much more we can do. And we're just you can tell by my background, I live on the side of a mountain in the middle of nowhere, the Great Smoky Mountains, where there was not broadband until about halfway through the pandemic. And so working from home was challenging and it was expensive. I could afford it as a physician, but my neighbors couldn't. They would drive their utility vehicle to the top of the cow pasture to try to upload their kids' homework on their cell phones because it was just a really different experience for them. So we still have a tremendous amount of work to do on all the broadband expansions, which is great. I love that I have it now on the side of my mountain, but how do we help everyone have access to it? And not just for healthcare, it's for education and jobs and, all the other things.
Yeah, no, absolutely. Okay, I have a question for both of you. Looking at your data, it is my experience that state level Medicaid data, for example, to examine prevalence of diet-related chronic diseases among different demographic groups are neither transparent nor easily accessible. Any advice?
Sure, I'll start. I would certainly echo from someone who was involved in a lot of advocacy prior to this role that it can seem a little hard to really access even a well-resourced state agency data like we had in Minnesota. Some of that is because of just how we're allowed to use data to administer the program and not for things like research per se. And so I think, the first step is making sure you have a good relationship with your Medicaid agency and the medical director or others who would be really interested in looking at population health level type data. I think if your state agency doesn't have that resource available, because not all do, looking at health systems that care for large numbers of folks in your state, because they will have insight into who's on Medicaid and not, and that can be a place to start. And so certainly looking at, or if there's clinics, fairly qualified health centers, they all do have some degrees of data that can give you a place to start and work out from there.
And I would say in North Carolina, there's a way you can request data. There's a sort of public facing portal that you can do that. We have the same thing for clinical policies. If we're not covering something that you think we should be covering, there's a way that you can go in there and say, hey, dummies, everybody else is doing this. Why aren't you in North Carolina? And then we can say, so we have that for data too. It's hard though. Data, I mean, our systems and our engines are very complex and sometimes difficult to pull the right information out of to make sure you're getting really what you're looking for. We tend to have relationships with some of the big academic centers who have access to our data. So sometimes working through UNC or Duke is a great way to get access to the data in those partnerships with our academic centers.
Yeah, no, thank you for sharing that. Here's another one for Shannon. As a follow-up, if Black enrollees who generally speak English also saw different rates of offerings of telehealth, is there something else at play?
Oh, absolutely. I mean, yes, without a doubt, the English is just one of many barriers. I think there's ongoing trust issues, certainly in North Carolina, I'm sure around the country, around healthcare, and given the history of how healthcare has treated and marginalized certain populations, that is alive and well. And so is this a safe way to receive care? And am I getting the best care, or am I getting suboptimal care? I think is a fear that I've heard from people. I think there's just so many different ways that healthcare in general creates barriers to care. So if you work a full-time job and there are no evening hours or weekend hours, or, just because you offer it doesn't mean you can access it. And I think I'm seeing fewer and fewer providers still offering telehealth broadly. Like, it's like everyone's like, oh, back to business as usual. But as someone who lives on the side of a mountain, it takes me a half day to drive into Asheville to have an appointment and wait in the waiting room. And, I've missed a half day of work. Not everybody can do that. And so telehealth has some real potential positives for people. I don't think we're talking about that as much as we should. And if you have a telehealth visit where you're stuck in a waiting room for an hour before your appointment happens and someone scheduled their work and meetings around that, that feels really disrespectful as well. And so we have a lot of work to do on the hygiene of telehealth, how we offer it, who we offer it to, and getting their feedback about how we do it well and don't do it well. Yeah. We're just beginning to learn what is working and not working. We need way more member focus groups to tell us and to help educate us.
Yeah. Yeah, no, all good.
And Hemi, I'd add two things just from my experience. So I still see patients, and I think one quote that from the pandemic and telehealth, as we were trying to scale it up in our healthcare system, that really stuck with me, that is kind of emblematic of some of the problems we're facing, is I was told that we build this system for like the 80% that it's easiest to access it, and then we'll get to the issues for the 20% that it's not as easy, right? And I think that's a mindset that a lot of people take when it comes to addressing new problems. I think that there's actually been defined as the inverse equity hypothesis, right? When a new advancement comes through, those who are most wealthy and well-resourced actually benefit from it, instead of it actually helping those who face the most barriers or have the most disparities. And then one thing that we actually cited in our report is we had asked a question using the CAPS survey to try to get at this kind of missed opportunities for care that anecdotally I've heard about ever since I started medical school training. A mom takes off a half day of work, takes 2 buses to get her child to a checkup, and is 5 minutes late and is told that she can't be seen, right? And so then that opportunity for care is missed, and that child misses immunizations, and we see that in our quality reports, and we're wondering why there's these disparities. And so we put a question in our CAP survey that said, in the last 6 months, were you ever told you were too late to be seen? right? And that was done by all enrollees, and we were able to stratify it by race. And we saw that there was a statistically significant difference between our Black enrollees and our white enrollees, with our Black enrollees more likely to be told that they showed up too late to be seen, right? And so that just hints to there are systems things that we can again use these conversations, use data to think about how do we really kind of structure whether it's reimbursement or other quality metrics, other things to really try to incentivize systems to address some of these things that drive the underlying disparity.
Yeah. Thank you for sharing that. And actually, I have a follow-up for you on Nathan. So there's a question from the audience. I think this ties into what you were talking about in terms of really understanding impact and thinking about how to sort of translate that into payment. So the question is, how did you measure the difference in outcomes for Black Minnesotans born in the U.S. compared to other Black residents? Do you have data by country of origin? And how are you going to use that data when you think about metrics and sort of payment measures?
Yeah, so we don't currently have really robust data around country of origin outside of United States. We're able to use kind of birth certificate records data to kind of link enrollees who were born in the U.S. versus those who weren't. And this is all work done by Dr. Justine Nelson, several years before I even joined the agency. It's also cited in our report we put out on deep poverty and its impacts as well. And so I think that it gives us a place to start. And, I think both within the Medicaid agency, but within our public health department and really within all state agencies, we're having a conversation about how do we do a better job of both standardizing and having more disaggregated data when it comes to things like race, ethnicity, language, geography, so that we can then, again, as we see different signals in the data, use that to focus who we're engaging with, how we're co-creating the priorities that we set forward. Because if we can, and we saw this somewhat in our COVID response when we were looking at rates of COVID-19 and vaccination rates amongst Asian Pacific Islanders in Minnesota, they actually looked pretty good. But there was a community organization, the CAL, the Coalition on Asian American Leaders, that worked with the University of Minnesota to look at death certificate data. And when they actually looked at the different rates of deaths in different communities by zip code, where we knew that there was more Hmong or Karen refugees, for instance, we saw that for those communities, COVID was the leading cause of death in 2020, for example, and their vaccination rates were much lower. And so we do need to keep pushing ourselves at thinking about how do we disaggregate data so that we don't come up with kind of some, they can be good or can be bad. And, and your actions are only going to be as good as your outputs are only going to be good as your inputs, right? And so continue to think, how do we have both as standardized as possible so that we can have good benchmarks and comparisons, but then also disaggregate it so that we are getting the kind of as close to possible as communities impacted and the solutions that they have.
Yeah, no, all very good points. And then I have two questions, one more for you, Nathan, and another for Shannon. And then we might have time for one more, and then we'll have to close the session. So get your questions in. So for Nathan, one follow-up. Will you discuss your efforts with Indigenous populations in more depth? What are you thinking about what will be entailed in that effort?
Yeah, so we're still, relatively early in the process. We have our own colleagues who work as tribal liaisons, and so I'm really working closely with them to go into spaces where we're already meeting and having conversations with American Indians and tribes to present. This is what we did with this last report. We look to do work similar to that. Is that something that you're interested in? We don't want to assume that this work is something that is high on their list of priorities, and then if so, here's the process we use. Does this work? Are there other ideas? And so we've met, both with the tribal and urban Indian health directors and social service directors at some of their meetings. And then we met with a couple urban American Indian organizations that work directly with urban American Indians who live in the urban areas of Minnesota, to really help, again, guide that process, understanding that there is more intricacy to the relationship between Medicaid and IHS and American Indian communities. And so wanting to, again, use the report to not only come up with some priorities for us, but also, what would the community like to either learn from the report, learn more about Medicaid so that they could continue to advocate for their needs, that we could lift up both strengths where it's worked well, and then also challenges, as there have been, both in Minnesota, and then what is the process of disseminating the report as well. And so we have 11 tribal nations in Minnesota, and the hope is to engage with each one of them. We have significant American Indian populations in the Twin Cities, but also other areas in Bemidji and Duluth in Minnesota. So the hope is to go in person, sit down and have these conversations. And so it'll probably take a little bit longer because we're both going to try to implement lessons learned and the differences in the community. But the hope is to come forth with something that might not look exactly the same, but hopefully has a similar impact as far as making sure that we move changes forward, that the community feels like it supports the work that they're already doing, and we really help strengthen the relationship between our agency and the community.
Yeah, no, thank you for sharing that. And then a question for Shannon, and then we'll do a quick round robin on for a last question before we close out. So Shannon, there's a question about, do you plan to replicate your efforts with other areas of care, pediatrics, cardiology, others?
So a lot of the things that we turned on, we've made available for everybody. And so you don't have to be pregnant to have access to a scale or a blood pressure monitor. There's some really, narrow parameters. Same with our prescriptions. A lot of them we thought initially were like, oh, this will really help with pregnancy care. But then we thought, no, this will actually help with people with diabetes and other kinds of care. And so we have very few things, unless it's clinically indicated, like lactation consultants, that would be exclusive to a pregnant population. So yes, we're thinking of things very broadly on how many people can access the services in the easiest way possible so that they can get the most benefit out of it. So most things are broadly available.
Great. Okay, last question, and then we'll close out the webinar. So what federal supports would be helpful to build on the successes you've achieved so far? We can start with Nathan and then go to Shannon.
Sorry, could you repeat the first part of the question?
What do you want the feds to do to help you in your efforts? Is there anything you'd like them to do?
Yeah, so I certainly have been really appreciative of the 1115 waiver approvals I've seen coming through, and the flexibility and kind of broadening our thoughts of how we could use that to address pieces of structural racism, like around re-enrollment and enrollment. That was really the key call to action from our report, was that continuous eligibility as a way to decrease some of the barriers seen by the U.S.-born Black Minnesota community. But continue to think about how's the policies that we have set in place, where can we have flexibility for populations that have historically faced oppression, faced barriers to this, who are facing other barriers outside of just healthcare, access to housing and nutrition. And so continuing to think about that, I think continuing to think about when they put out grants, could we actually incorporate things like we've used in the COVID response, SVI, a geographic marker of disadvantage, right? And so could we actually have tiered funding or more flexibilities for communities that we know already face disadvantage, instead of having to go there and prove that we know that high SVI face disadvantage. And so instead of having to collect all these codes for different diagnoses, could we actually just start paying folks who care for more members from those communities? And so I think there are a lot of opportunities to continue. Again, really heartened by what I've seen over the last couple of years. And I think we came up with some interesting ideas about how do we using the poverty level as the marker for how we determine eligibility. Is that really, does that need to be updated? Does that need to be tiered by different communities? I think there's really some great questions we heard from communities that we could, sit down with our federal partners and have broader conversations about, again, that short, medium, and long term.
Great. Shannon.
Yeah, there are a few things that are on my top of mind. One of the things is understanding the data on the less typically naturally aligned to telehealth service provision. So those things that are really high hands-on touch services and whether they should be continued in telehealth. So physical therapy, respiratory therapy, some of those non-traditional services, we need to study it. We need to understand what the outcomes are. And to have that be powered, it needs to be at a big national level, I think. And so I think that's very, very important for us. Kind of coming down on what permanent policy is. What are people going to cover? They keep kicking the can down the road. And it's very, very hard for states who are saying, this is what we're going to do. And then to have at the federal level, not to have there be as much clarity on that. And I know it's controversial and challenging and everybody wants everything, but that's something that I think would be helpful. And then the last piece I would say is around this digital divide, resources to support people that live in rural areas or live in urban areas that can't afford the technologies to have equal access to broadband, to devices, to the resources they need so that they'll have better outcomes.
Yeah, those are all good thoughts, and hopefully there'll be some in the future from all of those ideas. Well, thank you to both of you for spending the time today. Thank you for your leadership on these issues. These are, I think, percolating across the country, not just in your state. So it really has been helpful to hear your experiences and how that can be thought about at a broader level. So I just want to say thank you to the audience too for attending. I think hopefully you've learned something. My true belief is like flexibilities and innovation in Medicaid programs can chart a path forward. So it's really important to continue to learn from one another and in order for us to improve health and well-being and advance equity. So it's been a great discussion. For those of you who are interested, there was previous sessions for Medicaid leaders from Arizona, California, Kentucky, and West Virginia. That recording is available in the chat. You can go ahead and listen. A recording from this session, if you missed any of it, will be available as well. So you'll be able to catch anything you missed and share with others. We really hope you found all of these conversations useful. And before you go, if you would complete the brief survey, that would be really helpful. And I just wanted to say thank you to the Robert Wood Johnson Foundation for making all of this possible. It wouldn't have happened without them. So I really believe in the Medicaid Innovation Award and glad to see that we're able to recognize these 6 states. So have a great day, everyone, and thank you for tuning in. All right, take care, everybody.